Good morning to everyone that's just joined us. We're just about to get underway, so a very warm welcome to the Masterclass this morning. If you want to let us know where you're from, by all means, open the chat box up and say hello to us and let us know what organisation you're from. It's great to see everybody here this morning. Okay, so I think we're good to start. Just like to welcome you all to the Masterclass, the Digital Transformation at Speed Masterclass. And I'd like to, on behalf of the collaborative, welcome Jen Cohen from the Innovation Agency Northwest, who's going to be chairing the session for us this morning and guiding us through. So good morning, Jen, and welcome and thank you.
Good morning, Sharon. Good morning, everyone. Thanks so much for having me here today, just to hold some space and in the morning. And so my name is Jen Cohen, everyone, and I am the head of coaching at the Coaching Academy for the Innovation Agency, which is your Northwest Coast AHSN. And before we start, I'm going to ask Effie, can you run through a little bit of the Zoom etiquette for us?
Hello everyone, I am Effie from Aqua. I'm your technical support for the day. I am going to be posting shortly my mobile number in the chat box so that you can contact me if you have any technical difficulty during the session. Just to let you know, everyone will be muted at the start of this masterclass. You can mute or unmute yourself by clicking on the microphone button on the far left. And you can also use the webcam or stop using the webcam by clicking on the video icon on your left as well. If you want to participate or say anything during the masterclass, you can put your hand up by clicking on participants. And you can then see that you have options to raise your hand or clap or put emojis on, depending on how you wish to react. You can put any details in the chat box if you have any questions, and the chat box monitors will be picking that up today during panel discussion, and you can have your question answered. Also, we have enabled live captions, but if you don't want to have subtitles today, all you have to do is click on live caption and click on disable, hide. Yes, and hide the subtitles. Sorry, I got stuck there. But that is it from me. But yes, please be patient with the technology. If we can't answer your questions, we will have some time towards the end, so you can still ask your questions. And that's about it from me.
Great, thank you. So I wanted to also introduce the team who's really responsible for this event. And so just to give you a little bit of a rundown, I'm here for one of the partners, the Innovation Agency, the Northwest Coast, and the other 5 organizations here are Aqua, the Advancing Quality Alliance, NHS, Northwest Leadership Academy, Northwest ADAS, MIAA, and the Northwest Employers. So this is a nice group of folks who it's been nice to be working with you all over the last couple of years, and seeing these master classes really come to fruition is really exciting. So we've got a really great morning for you today. I mean, what a time for us to hear from these stories, because we're sort of in the thick of it. So digital transformation will be our focus today. You can see the program. We're sort of started here, but we're going to turn over pretty soon to our first speaker, and we will have Q&A between each of the speakers. So please be sure to be thinking about your questions, your ruminations in the chat. Definitely just provide all the comments you can think of as far as questions you have or wonderings or thinking about across the system how folks are managing things. So I think this is going to be a rich conversation. I'm really excited to be here today. So we also are on Twitter. And then the hashtag is #CollaborativeNW. So that's pretty simple. I'll definitely be on there. And we're recording the event, as you may have noticed, and that link together with the slides will be provided to you after the event. So I think we're good to go. Oh, one more thing, we're not having a specific break, so just make sure you stay hydrated and get your beverages and take your little breaks when you need them. So before without further ado, I'd love to turn it over this morning to Sneh, Jenny Patel, and Matt Skinner, who are both here from FutureGov. And FutureGov is an organization that supports people with digital transformation. So we're delighted to have Sneh, who's the director, and Matt, who's the chief exec. And I'm going to turn it over to you guys to do your sharing. So thanks so much. And I can't wait to hear what you have to say.
Thanks, Jen. I'm going to try and take over the screen share. So let's try that. Fingers crossed.
It's all about digital transformation, Matt. You can do it. We all take risks. We're at a gracious time.
Can you see that okay? Fab. Well, yeah, good morning. And thank you very much for having us. So thank you for the introduction. I guess my name's Matt Skinner. I'm the CEO of FutureGov. I'm joined, I hope now, by my colleague Sneh, somewhere in the audience. I saw her. Sneh, do you want to say a quick hello?
Yeah, good morning. Hi, I'm Sneh and I'm Principal Consultant at FutureGov. Lovely to be with you all this morning.
Super, thank you, Sneh. So Sneh and I are going to kind of tag team our way through this presentation this morning, and then we're delighted to take some questions from you a bit later too. But I thought just to kind of kick things off, for those of you who don't know us, a bit of an intro. I mean, FutureGov is a change agency that works across government and health, and we broadly bring a kind of range of skills across design, technology, and change to help clients solve a range of problems. And the approach that we take is always one that is design-led, which means it starts by deeply understanding the kind of needs of the citizens, the patients, the end users that we work with, and that includes frontline staff who deliver public services, before we help to kind of design new services, often new ways of working, and often new products and new technology to support those services. So we really firmly believe at FutureGov that public institutions are the best place, are sort of best placed to deliver change for communities. And I think over the last year, we've seen time and time again, really, that kind of centralized approaches to solving really big, complex problems don't work. And I'm thinking of examples like the kind of centralized response initially to kind of the A-level results that kind of didn't take into account some of the views of teachers and local schools' insights. I think you can see really interesting results from the vaccine program that's been heavily reliant on using kind of a highly sophisticated community engagement to ensure that we're getting that uptake. And it's really our view that we need to think quite differently, I think, about the link between central and local, from where policy happens to where people feel the change in their communities. And increasingly for us, I guess, the role of public institutions and health institutions is to deliver the change alongside their communities. And we remain really excited about the potential for things like ICSs to play that role at a very place-based level. And we've seen the most success, I think, over the last year in particular through our work, where we've devolved decisions and things down and action to communities. And I hope that will come through from some of the examples that we kind of show you today. So we've been doing this kind of work for over a decade. A huge range of experience in the company across kind of public and health services. And I think just some high level kind of lessons for us as a business over the last year, actually delivering with clients like yourselves in this space, has been that we've had to really pivot, actually quite fundamentally, a lot of how we have been helping support clients across the public sector in many different ways. Like immediately at the start of last year, and the case study that Sneh will share with you, we were asked to kind of quickly help a local authority and a kind of range of health partners to respond to the issue around shielding and how to put in place emergency kind of food services to help them. But we've seen a real uptake in the last year for creating digital solutions, but doing them at a pace that we've not had to do at the same level previously. And that's forced us to take some shortcuts in places. It's forced us to get much more quickly into delivery, building and testing solutions. And that sometimes felt a bit uncomfortable, actually. I think for an organization that's used to kind of, delivering in a kind of certain way. And we'll share some of that through the experience through the case study that we'll talk to you a bit later. But it's also forced us, I think, and clients to look at problems in a really different way. One of the things that we did last year, for example, was to work with the North East London Commissioning Group, and we were asked to help design and implement a digital solution to manage PPE stock levels. And when we looked at how that was currently happening, it was almost a bit like a kind of Russian doll analogy. There was kind of layers of information and data held on paper and in spreadsheets that kind of wasn't really kind of talking to each other, and people really trying to do their best around that quite difficult environment, I guess, of information sharing. But we had to really quickly, it was about 4 weeks, go through a rapid cycle of doing user research, designing a solution and testing a minimum viable product that helped to kind of make that better, that brought all of that information into one place and allowed people to share data across hospitals, across CCGs, across the council, in order to kind of manage those stock levels. And it was really successful, but it was done at a pace which felt really different to anything that we'd done before. And actually that solution was then scaled to other areas of London. Now, I remember this quote, reading this quote at the beginning of the pandemic, and I think I can't really understate how true this feels right now. It's just that everything we do before a pandemic will seem alarmist, but everything that we do after will seem inadequate. And I think that certainly felt true for all of the work I think that we felt like we did before the pandemic and have seen continue after. FutureGov says quite often that most organizations weren't designed for the internet era, and they certainly weren't designed for pandemics. And I think ultimately what that means is that they weren't purposefully designed. Like, citizens' expectations have been rising around this new technology for a long time. And I just think that at the moment, there's no way now that they'll accept us rolling back to some of the sort of face-to-face service delivery in many areas that are now kind of entirely digital facing as a result of what's happened throughout the pandemic. And responding to COVID, I think, has pushed many things forward rapidly in the last year in a really positive way. Like, as an organization, like we've learned and achieved a lot. And I don't think that anyone can really argue now that there's a need for better designed organizations and technology. And it's essential to the ongoing delivery of public and health services. So we're going to share a case study. I'm going to hand over to Sneh to talk through some of the work that we delivered in Camden last year with the council and health partners. Some of the things that we've learned, some of the reflections that we've had, which I think are really relevant actually across government and health organisations. I'm going to hand over to Sneh.
Brilliant, thank you. So good morning, and before we kind of dive into the detail, I was reflecting this morning on the work that we did with Camden, which feels like a lifetime ago. And was actually from beginning to end not the longest piece of work. It was spent only a few months, but the amount of work that was delivered and the incredible team working that took place over a fairly short period of time is actually quite astounding. So to give you just a little bit of context before I dive into kind of what we did, we've been working with Camden for a number of years, and actually prior to the pandemic, when just before it hit, we were doing a really interesting program of work with them looking at tackling employment outcomes across the borough. So we had an established team, and we were working very closely with Camden colleagues. Our team was very much embedded in existing services. So when the pandemic hit, and they decided that they wanted to kind of pivot their focus to the pandemic, given that central government was taking such a long time to come up with any clear direction. We were kind of very well placed because we already had those existing relationships and we already had the knowledge of how the team worked. So I was just counting as Matt was talking, kind of how many people. We had about 45 to 50 people working on this, and bearing in mind it was all remote. It wasn't just kind of FutureGovers and Camden Council colleagues. We brought in SMEs, and I'll talk about some of the kind of expertise that we brought in to kind of bolster our response to the pandemic and working with Camden. But it was a huge amount of work. And what I'm going to do over the next few slides, hopefully, is articulate kind of the problem that we were trying to solve, the approach that we took, and then as Matt said, some key learnings. And we'll go into a little bit of detail around certain aspects of the work because it was quite a broad programme. And then, of course, we welcome questions as well. So Matt, do chip in throughout as well. And let's kick off. So really the problem that Camden, as many councils wanted to solve when the pandemic hit, was to mobilise as quickly as possible to ensure that residents that were identified as the most vulnerable were getting the support that they needed, but also looking beyond that, so anticipating that medium to long-term need. So we know right now, for example, that food and prescription drugs are an absolute priority. But actually, and I'm sure you'll remember, there was a lot in the press around, okay, well, we're anticipating, we very quickly saw things like domestic violence cases going up. So what are we doing beyond the kind of emergency priority needs to make sure that we're well placed as a council to support those residents? And our response and the way that we worked with Camden and that we work with all of our partners, as Matt said, was to take a needs first approach and really understand who the most vulnerable were, looking at the data, and seeking those people out to make sure that they were actively supported. And it was our understanding of vulnerability that really reflected the way that we addressed this work. So guiding people to the support they needed, ensuring that they received those essential goods. And then also there was an ambition, and I'll talk about this as kind of part of the learnings, to work with the wider system, as VCS partners, third sector organisations, to ensure that they were able to maximise their impact as well. But again, the kind of disclaimer is very short time periods, lots of actors, everyone trying to figure out what was going on. And really, as I said, preparing for that long term. So we took a multidisciplinary approach, as I've already mentioned. So in FutureGov, as Matt mentioned, we've got tech specialists, org designers, service designers, user researchers, a real wealth of skills that are often deployed to help design, develop and deliver improved services. Again, this is a very different context. We're basically doing emergency response. So everyone had to kind of adapt and really make sure that the kind of skills that they had honed in over months and months were kind of deployed overnight and working really at pace. And in addition to kind of that kind of set of skills, we obviously had the expertise of Camden colleagues, and we worked very closely with a number of teams I'll mention shortly, but across communities, public health, to make sure that we had a really good understanding. We were building on all of the knowledge that the council had of its local residents. But then we also brought in, for example, logistics experts. So we had somebody from Amazon who had been involved in helping set up Amazon's food delivery service. So knew the context, knew the ecosystem, knew what the options were, and could very quickly test different ideas. Because actually, when we started working with Camden, and you can see on the left, the kind of developing that food response was the very first thing we did. So over a couple of weeks, we worked with them to kind of test an approach to say, how can we get the food that's needed to residents, and recognizing that they had, again, lots of different needs. So, there were some people, for example, who were able to cook their own food, and they just weren't able to go and get it. So for those people, it was, how do we get groceries to their house? There were others who weren't able to cook, but had access to a microwave. So therefore we could give them healthy microwave meals. And there were others who just didn't have the ability to cook for themselves and would have traditionally been dependent on carers, for example, to come in and help them. So for those people, it was pretty much kind of hot meals at their door. So being able to do all of this and test it and really implement it quite quickly required a whole breadth of skills that went beyond FutureGov, went beyond Camden, and required us to bring in that wider network, which obviously, when you're working remotely, is a challenge. So as far as the way that we did this, and I was kind of doing another workshop with a colleague the other day, and he talked about kind of principles as being your gutter guards. So if you think about bowling, you try and drop a bowling ball down an alley, and your kind of gutter guard to make sure that you don't go off track, and that's exactly what these principles were. So we agreed these up front with Camden to make sure that we were all on the same track, and that the work would be delivering the outcomes that we needed, even recognizing that there was a lot going on. I'm not going to read off the screen, they won't surprise you, but I think what it's fair to say is, although we did this and we did, as we always do, put in governance at the beginning and have a clear set of principles to kind of keep us on track, it did feel messy. We were allocating distinct roles and responsibilities, virtually with people that hadn't necessarily worked together. We were working at pace in a pandemic, while people were living through a pandemic, kind of getting used to working remotely, 10, 12 hours of back-to-back Zoom calls. And there's a difference between kind of having subject matter expertise and having sector knowledge. And we were having to bridge that gap. So, it was fantastic having logistics expertise, but that didn't necessarily mean that they had the local government context. So lots of different challenges. But I think the main thing, and Matt's already touched on this, is that it was less about designing, testing and iterating, which is our is our kind of standard approach. And it was more about, let's do some quick and dirty research, let's figure out what we think we need to do, and then let's crack on and do it, because we just don't have time. You can move on to the next slide. Brilliant. So we worked over a couple of phases on this, and the primary focus of the first phase was really to serve those needs of the shielded population. And as I said, it was a truly multidisciplinary team. We had initially 3 months to work together, and it was all about supporting that shielded population. So if you move to the next one. Yes, so really, as I've said already, we wanted to look at those immediate needs, and then making sure that in addressing those immediate needs, we were also understanding what these residents were fundamentally facing, and then being able to, from those insights, ensure that we were prepared to meet potentially medium to longer term needs. We'll talk about this in a bit more detail shortly, but I think the thing to note here is, obviously in a pandemic, when there is so much uncertainty and so much need, really, it's actually easier to focus on the immediate needs, and it's quite difficult to kind of have the headspace to then take a step back and look at kind of that resilience and that medium to longer term resilience. We set up the programme to ensure that we were doing both. So we had one team that was looking at the shielded and that emergency response work, working with the communities team. And then we had another team, we called them enhanced support, that were looking at anticipating this medium to longer term need. And they were working with the supporting people directorate. And then across the two, we had, essentially, if you think about it horizontally, kind of sitting underneath those two, we had tech specialisms, we had a VCS work stream, we had a number of different work streams, essentially, that we felt a solution design and implementation team, and then a service directory team as well. So we had 4 kind of cross-cutting work streams that supported the kind of immediate response and then the medium to longer term response. Great. So this was the blueprint that we developed to really think beyond emergency response, and how Camden could really ensure that residents were getting the support that they required. We identified these kind of core pillars, if you like, of support that we felt were really important, and where the data was showing us there was kind of pressing and increasing need. It'd be fair to say that as far as kind of implementing responses quickly, on the food and medical supplies, so ensuring, as I've already said, that people were receiving meals, be that through groceries or hot meals, and medical supplies, so prescriptions, that happened very, very quickly. The rest of the kind of different elements of support, I think it's fair to say, by the time we finished our work, what we had was a really valuable set of insights for the teams to take forward and to act on. But we didn't manage to get through all of these things, unsurprisingly, in a few months, to be able to kind of test and deliver new responses. So there was it was a mixture of kind of delivery and design, I would say, and then that really depended on kind of the nature of the support. Okay, brilliant. So we're going to spend a little bit of time just taking you through a couple of key aspects of the support that was provided, just to give you hopefully a little bit more of an idea as to what we did. So the directory was an online directory, resident facing, that we turned around in a week. And it was really a tool for residents to find the best community service for their current situation. And I think we've got some learnings that Matt and I will share in a minute, but we did stand this up very, very, very quickly. And actually, this is something that is even now still very much a key tool that residents are using in Camden. And since we deployed it last spring, there have been a number of updates and refinements to it off the back of kind of hearing what residents are finding useful and hearing what staff think residents need. So this has very much been refined and built on since it was first deployed last spring. If we move on to the next one. Yeah, so yeah, Matt, I don't know whether you want to kind of bring some reflections as well here, but I think, the idea was that we would build this open source so that it could be used by other local authorities. And many people did, but there could have been potentially much more benefit, we think, to this. We did talk to a number of local authorities about what they were doing, and actually, again, it's very difficult when everyone's trying to kind of meet the needs of their own residents to think about collaboration and to invest that time. So potentially, our reflection is that we could have worked at greater scale, and this could have benefited more people more quickly. We did, again, have to deprioritize some things because of time, and kind of a question to ourselves was around reporting and performance analytics. Did we get all the information we needed to into the right hands, and did we miss anything, really? And then a question around, well, not a question really, a learning, which was, because we were doing this so quickly, we had to prioritize what residents needed. And content design therefore became a really high priority, because if the information wasn't intelligible, if residents couldn't easily access the information they needed, there was no point in doing this. So there was a huge focus on, user need rather than necessarily engaging practitioners really widely to make sure that they were comfortable. It was we were going straight to the heart of the users. Matt, is there anything you wanted to add to that?
I think those are sort of the main points. I guess the really interesting thing from this bit of technology, it was, it's quite lightweight. It was open source so that others could reuse it. And we worked with a number of health organizations, one in Tower Hamlets, who also adopted it. So it felt like there was the application could be much more broad. But I think the challenge was the sort of, I think somebody in the comments might be talking about it, but the kind of lack of skills in order to be able to stand that up and to kind of provide that really good contact, the really good data, etc., that just wasn't there. So yeah, I think we learned a lot from that. We're like evolving that product with a number of partners, including health and local government at the moment, because we feel like it is something that's still super valuable. We put the hands of that service information like to users, but yeah, it wasn't the easiest to get stood up.
Thank you. One of the other key aspects of support we wanted to talk about was Beacon. You can hop on, Matt. So really, Beacon is a platform. The ultimate dream with Beacon was that it would be a tool that was used by agencies across the system, so that you could have volunteers accessing it, VCS organisations and the council to essentially pick up. So the council team would receive calls, be able to log them and log the needs of residents, and then it would be able to be picked up by the right partner in the system. The need would be addressed. It would be then updated in Beacon, and there'd be a single view across the system of resident need, and ensuring it was addressed. In reality, the partnership working was really tricky. And actually, what we found, particularly in the kind of VCS work stream, was there were kind of fundamental relationships that needed to be invested in that might have been neglected over kind of the previous months. So what we had anticipated being kind of quite open and engaged interest in kind of working together didn't necessarily materialize. So I think it's fair to say, our ambition for this to be a kind of system-wide tool was not met, but actually the fundamental need of Camden residents was, because what Camden Council needed was a tool where they could easily kind of register, identify, log and refer need to ensure that people, for example, that needed food parcels were getting them. And that's essentially what it was. So if you flick to the next slide. So this was the ultimate ambition, and there's lots of words and it's a bit complicated, the diagram, so let me just quickly break it down. Essentially, what we'd hoped for was that we would have outbound and inbound calls coming in and registered through this tool. And then once the calls were registered, you'd have your multidisciplinary team plus your VCS experts looking at the residents where they were flagged to say, okay, so for example, this resident has multiple complex needs. Who is the best person for our multidisciplinary team to address those needs? They go away and do it. We then log that back into the tool. Now that actually did work, because that was all within the council. So that's why when I say kind of we fundamentally delivered what the priority need was, it's because we were able to mobilise and enable that partnership working within the council. Where it became slightly more complicated was where we'd anticipated, for example, VCS partners being able to log in, pick up those referrals and address them. we started on inbound, and I can't remember the exact call numbers, but there's a slide later on data. But you know, this really, and it still is, the customer facing tool in Camden. And again, just like the directory, since we first deployed this last spring, we've been working with Camden over the several last months to kind of refine and update this. So in short, you can see it's an application that enables local authorities to keep that combined list of vulnerable people in their borough, record their needs and keep track of their fulfillment. And as we've said, you know, capturing those resident needs and making sure that they're getting the right support is really important. There is obviously kind of a relationship element to where voluntary sector support is required, and I know lots of work has been done around that in the last few months. But obviously, as I've kind of said ad nauseum at the beginning, when you're trying to kind of mobilize these things, you need to work with kind of these existing infrastructures that you've got to deploy something quickly. So we were primarily working within council teams with Beacon. So there are a couple of screenshots here, so you can see the kind of information that was recorded, and it was very simple. So as far as the needs, you know, being able to assign needs in a very simple way, being able to see who the calls were assigned to, whether they were high priority or not, so that essentially every day what would happen is, you know, people would call agents, would record all of this information. Then the food team, the Shield Hub team, would take an extract and they would have a report. So they would know which residents need food, and they would use that to then make sure that from a logistics side, residents were receiving it. So there was a lot of overnight data cutting going on, because obviously we needed to keep the system live as long as possible to make sure that we were meeting needs as soon as possible. I want to move on, Matt. Great. So this is a summary of, and this is a point in time back in last spring, when we were essentially obviously having to train the agents as well. It wasn't just about kind of building a system and then it being ready to go, but we had over 30 agents using Beacon to make calls to capture the needs of vulnerable residents. So a number of team leaders, team manager, and you can see, you know, there was kind of simple needs, complex needs, and the team was set up to kind of best address those needs as they were coming in. I've already mentioned the multidisciplinary team, which was a really, really important, and actually something that Camden had wanted to test for a long time. So from their perspective, it also enabled them to speed up testing of approaches that for them had been really important for a long time. So the focus on early intervention and prevention was something that they talked about, they'd explore different options, but here we were with kind of many complex needs, a huge number of residents, many residents who might not have even, you know, been on the council's radar before because they'd fallen. They were kind of on that line between previously, you know, you've got your complex needs where you know that people are in need of council services, they're on your radar. There were lots of people that were kind of on that at that tipping point, and actually COVID tipped them over the edge, and it meant that the council was identifying a whole new kind of cohort of individuals that needed help, and ensuring that there was a multidisciplinary approach that was robust and able to kind of pick up and address that need as soon as possible was really, really important. And then just a couple of testimonials. So yes, obviously, as we know, with digital transformation, adoption is sometimes one of the biggest challenges, but actually very quickly, it was appreciated and recognised because they were literally using a spreadsheet before this. Some challenges. So I think, again, not to read through all of these, if you were to ask me kind of from these, what I'd say the top 3 challenges were, I would say that decisions had to be made much faster in a crisis and were delegated down, which at the time was fine. But when you're kind of a week in this kind of a working arrangement is a month. And when people are asking, you know, why did you make that decision, or, you know, what was the rationale, you can give that context. But by then something else has happened. And I think that the pace of it was challenging to kind of bring everyone on you know, the journey as and when things were happening, because you just had to really get on with it. And services had to be stood up overnight, and we had to improve things, you know, while running it. And as I said, we do take a design, test, iterate approach, but this was on a different scale, and we had to be prepared for things not to go right the first time. but make sure that we were really managing the most significant risk and prioritising our energy accordingly. So yeah, lots of learnings, and it's really great, as I said, that Camden is still using the tool and building on it as they continue to kind of address resident need through the pandemic. And I think that's everything.
Oh my gosh, that was so interesting. Thank you, Sneh. Thank you, Matt. So I'm sure people have questions. I think we're okay on time to do some questions here for a little bit. So I know I have some questions, but I'll ask Helen and Pam if they've seen anything come in. But I definitely have questions.
Jen, do you want to kickstart us? Because I think people are just looking in. I knew you would like to.
That was the right answer, Helen. So yeah, I heard you talk about a lot about relationships and communication and pace. And I'm also have questions about design thinking and how you did this so quickly. Is there anything that would have helped that you didn't have, that like if you could have waved a magic wand and said, oh, we really need this to help us manage this pace, manage the turnaround of information? Is there anything that would have helped, or what would you do differently next time?
Sneh, there's something that pops to mind. So after this work, there was basically there was a big bit of kind of, well, a big sigh of relief that some of it had worked and that we got it. But then there was a lot of reflection on like, how could we improve the information and the data? And actually there was a jointly commissioned piece of work by Camden, involved a number of health partners actually and the VCS, to look into specifically how can we share better information and data. Actually it was a piece of work that I think MHCLG funded, and all of the outputs are open. But it was a really interesting bit of learning, and we were involved in that because I think one of the things that it felt to me, like particularly around sort of the director of service, but like really relevant to kind of the beacon work as well, actually, was just the information is kind of everywhere. Nobody really knows, like, and we know this, right? But like consent, what can I share? What can't I share? And that held things back immediately, I think. Just the kind of lack of trust actually between some of the agencies involved in that way of working, and not deliberately not wanting to share, but just because people don't quite know like what the parameters are. And I think having reflected on that, like actually, anything that was shared, nothing sort of fell over. Nobody got in trouble. And so there was a kind of good reflection point after that said, actually, if this, if we were doing this again, we'd be able to do this quite differently. So I'd recommend like having a look at some of that work. There were some really interesting reflections from health colleagues and council and VCS in that work. But Sneh, yeah, you were about to.
It was actually related to that. The kind of the data governance process within the council, when we started this as well, was tested. Because obviously we were standing up tools really, really quickly. And we were, we really wanted to be able to share information about those vulnerable residents so that their needs could be addressed quickly. But I think early on, some glitches with that meant that we were slightly delayed. But we did manage to kind of overcome those things fairly quickly. I think besides that, the unsurprising response of time, it's really easy to say this now, but if we'd taken a little bit more time at the beginning to really take a step back, I think we might have been able to, for example, with the kind of enhanced support, say, moving insights and potential responses to addressing domestic violence to actually testing things, we might have been able to. But again, we had to prioritize, emergency response. So I don't know if we do it differently, but yeah, the luxury of time obviously wasn't there for us.
Great, thank you. I think we might have some more questions coming in too.
We do, Jen, so from Sharon actually, so some great examples of having to respond under pressure. How do we encourage more of this when there isn't the same pressure in the future? So how do we hold that game stuff of working? Any thoughts?
I mean, my immediate response is, do we want to recreate those working conditions again? I'm not sure. But I know what you're saying, which is how do we, well, I think I know what you're saying, and correct me if I'm wrong, which is how do we ensure really robust like prioritization and make sure we're not wasting our time on kind of tasks that aren't actually that important. I think where we were really lucky, and it's not luck actually, it's we know that Camden's like this, but council leadership were really committed to this. And there was no question about what we were doing, why we were doing it, and what was required. And both from the council side and from our side, we felt that we had complete support from the chief exec and from the leader. And I think having that strong leadership is really important. And because everyone was united by a very clear goal, all of the kind of noise and bureaucracy that you can sometimes face when you're trying to make decisions disappeared. So I think, let me just make sure I'm answering your question. How do we encourage more of this? I think there is a role of leadership to do that, and having kind of a clear commitments, and being shown to kind of actually deliver them or be committed to delivering them, I think is really important, because I think that trickles down, and that's what we saw. We had really junior staff on both sides that were going above and beyond because they felt empowered. They knew what they were doing, they knew why they were doing what they were doing. And there was that kind of collective, which was something that I would like to recreate, that kind of collective force. Even as I said, that you're the kind of 50 faces on a screen, everyone was united to try and improve things. And that is something that I think should be, we should try and emulate. And I do think that needs to come from the top, and then hopefully we trickle down.
I think related to that as well, I was thinking of that, I mentioned the sort of PPE example with the North East London Commissioning Group. I think one of the things there, so there was a really clear need, I guess, really a really obvious problem that we needed to solve. But I think, again, it was a really multidisciplinary approach that we took, so involving a number of staff from hospitals, from local authority, from the commissioning group as well. But I think the thing that really made the pace of it work, actually, and the ability to test, was just the kind of, I would describe it as a really kind of autonomous team, actually. So whilst the problem space was kind of owned and understood by the leadership, the delivery of the work was really owned by the team. And so some of the usual governance, some of the usual kind of questioning of are we on track, the stuff that can sometimes creep in, I guess, to kind of make sure that that we're delivering the right problem, so that was all kind of owned by the team, and therefore they were able to deliver and kind of get on with trying different approaches, testing things really quickly. So something about how you give autonomy to project teams, I think, is really interesting, that we've been learning, I guess, from that work, from the Camden work. How do we release some of maybe the controls around some of this stuff to test things in a bit of a different way?
Yeah, absolutely, Matt. And Claire in the chat box says it feels like it's about risk appetite and culture, and I agree with you, the leadership side of things as well, Snee. So just another question from Dilys Quinlan, a practical one. So were the people who were in need able to directly contact Beacon, or did they go through other agencies to get access?
So they would call, their need would be recorded via Beacon when they call the council.
Okay.
So that was kind of the interaction. So they'd call up, and there were outbound calls as well. So as the data got better and we were getting central government lists as well, when outbound calls are happening, it was kind of, it was the council staff that were kind of the contact point, and then Beacon was, if you like, the tool through which needs were identified and addressed.
We were very keen again. We had loads of ideas around how you could start to push that down further, though, I think. So working directly with agencies, allowing them to be able to record that information, so that actually, again, that kind of getting out of the way bit, it wasn't one agency, like the council, kind of preventing a much more community-based approach from taking place. But we didn't quite get there last year. I think they're still very much keen to do that. We did some work on it recently. And I can see that being something that is definitely on the roadmap for it. I think the challenge, I think we thought this could be a really great tool for the sector. Again, it's all kind of open source code as well, but there was a comment earlier about the skills in the sector to kind of pick up those kind of tools. I think that's definitely a challenge, particularly when you're having to deliver at pace, but also it's a shame because it feels there's a bit of a missed opportunity to kind of join things up for residents, when you've got neighbouring sort of areas who are using different tools and different ways of working, I think.
And residents don't always work in those boundaries, do they, either? We don't collectively. Sorry, Jen.
No, I was just going to say that was my question in the chat as well, was around, what can we learn now about needs for deployment of open source tools, right? So it's sort of that after the fact when people go, oh, if only I had known we had this thing that we could use, right? But it's like, well, then we do, like, let's be ready to deploy things like that. And that might be a very simple sort of convening some workshops around how do you get your organization ready to adopt open source.
Yeah.
That's pretty simple.
Yeah, I think it's the investment in skills and things.
Yeah.
So it's probably the bigger challenge. The actual, the information sharing, I think, is getting better and better. I mean, there's mechanisms in like local gov, particularly in London, like this was getting shared around like the London councils and things because of existing forums, and that happens, across country. I think MHCLG joining things up in local gov, but similarly in health, actually, that PPE tool, that was an open source tool that we built, and they could North East London Commissioning Group started using it for different purposes without us sort of knowing. And that was great because we then were able to kind of learn from those experiences and build it back. I think they were using it to kind of manage some of the demand around mortuaries and things that were happening at the time. So like a range of applications of that tool. And then again, it was kind of like, well, we built this thing, like we want to offer it to the rest of our colleagues in the sector, but making that leap, I guess, was hard. I think there was a lot of pressure last year, obviously, around that, but they're still out there. They still exist. So if you're interested to use them, go ahead.
I think that's a great way to sort of draw this, all together, is to the what now, right? The and now what. So, thank you so much for sharing this morning. This has been fascinating. I feel like there's probably a lot of follow-up that folks are going to want to do. So I anticipate you'll be hearing from folks. I know that we're going to be sharing slides and helping folks stay in contact, but absolutely, I mean, to be continued, right? So it's just another iteration of the work, the digital transformation work. So gosh, thank you so much. Is there anything else before we sort of shift gears? Okay, well, wonderful, thanks. That's a great way to kick things off for us. And now we're going to hear a little bit about another community. So this, again, the common theme here, connecting communities and digital transformation. What I'm loving about these themes that are emerging is it's all about relationships. It's all about community, really critical wherever you are. So we're going to hear from Paul Fleming next. So welcome, Paul. Good morning. And you're going to tell us about connecting communities in Blackburn with Darwin. So you all have had as we've all had, but quite a road over the last year. Paul is a recognized technology and digital leader. He's going to be sharing some innovative digital projects that have happened and what the lessons learned have been. So another perspective, another lens. Paul, thanks so much. And we're looking forward to hearing about Blackburn with Darwin.
Thanks a lot, Jen. Can I just check that you can hear me okay? Okay, thanks, and hello everyone. So just to let you know, I've had a really interesting approach to this week. I moved house during this stamp duty rush. We moved house on Wednesday, and I'm going to talk about digital and change today. The change that I've had this week's been kind of overwhelming, and on the digital side, I've got no Wi-Fi at home and no internet, so not a great start. And then, could I find my badge to get in the office today? Absolutely not. It's in a box somewhere in this new house. So quite a lead up to today, but I'm really pleased to be here. Also quite humbled and slightly like imposter syndrome going on, because every organization that I've seen and spoke to has done amazing things through COVID. So it's humbling to be asked to come and speak, but likewise, like any other organization, many organizations could come and sort of talk about very similar things. So thank you for having me. I'll apologize in advance for any cliches, any COVID crisis cliches, and if I state the obvious, which I'm quite skilled at doing sometimes. There'll be some similar themes, and there'll be a bit of repetition from what Sneh and Matt have been through, because we've done some similar things that I'll touch upon. And I'll just say that we're on a digital journey here. We've not got this cracked yet. So I'm going to just talk about our journey, how we're building maturity. You know, I'm constantly in awe of other councils that I see across the country and NHS friends that I've got. I was in the NHS 14 years before I joined this council, and I've kept a close eye on what's been going on through the pandemic, and I'm always blown away by what's happening. So this is a journey that we're on, and we're building that maturity. So just a bit of background to me. I started here at Blackburn with Darwen Council in 2018. So I've been here just exactly 3 years. And my background, as I said, was NHS for 14 years, working locally, regionally, and nationally. I worked across Greater Manchester and across Merseyside. Then I went into NHS England. I worked on the WannaCry response when the NHS was hacked a couple of years back. So a lot of NHS experience, and I was kind of new to councils, although I'd worked with councils. Some people on the call today, hello, Paul James, worked with people when I was in Greater Manchester across health and social care and working with councils. But this was quite new to me when I joined, and a real eye opener. So on the slide here, this is Blackburn. This is who we are. You'll see I presented this to NHS colleagues before, because I think when the NHS looks at councils, a lot of the time it's looking at social care, but this is about place, and the councils. What drew me to work in local authorities is the wider determinants of health and the experiences that we've got around sort of the whole person, the whole family, the whole community. So you'll see on the picture there, we've got the cathedral, a beautiful cathedral in Blackburn. We've got a brand new college building. I'm a governor at the college as well. We've got a huge college university campus in Blackburn. We've got a cultural quarter with King George's Hall, a fantastic old venue. And I was in a band once, and I played that before I came to Blackburn. It's the only time I'd been to Blackburn, was playing at King George's Hall. So that was nice to come back to. We've got a really modern business quarter, cathedral quarter. You see the mirrored buildings with the Festival of Making happening, where you can see a crowd of people and a man doing some sort of juggling circus techniques. So we have this International Festival of Making that comes every year. We've got wonderful parks, libraries, the Wainwright Bridge, lovely piece of design that's currently being painted in the colours of Blackburn Rovers. We've got museums. We've got Lancashire Tech Talks, which is on the bottom row near the left. This is a burgeoning digital community that we've got in Blackburn. So that's an introduction about the place and Blackburn. We've also got some major challenges. We've got, out of the wards in England with the most child poverty, of the top 5, 2 of them are in Blackburn, the other 3 are in London. So you can see that the challenges that we've got, huge challenges around deprivation. We've got real diversity in our communities, so one of the most diverse communities in the country, one of the youngest communities in the country as well, particularly in Blackburn. And Darwen, we're a dual town authority. Darwen's a lovely market town. So that's a bit about the place. So I came here in 2018. We've now got political leadership over a portfolio for digital and customer services. And that's a really important point, because we brought basically a cabinet member over to look at the digital agenda. And it was a real step for the council to make when they brought me in. So they brought me in as a director of digital and business change. So that was bringing digital to the top table, and that was a move that has been replicated across the country many times now, but really important. I've since gone on. I'm now the strategic director of resources, so as well as digital, look after finance, the customer services, the front desks of the council, audit, insurance, many things, projects, transformation. I've got a team of about 350, and the council employs about 2,500 people. Okay, so I'm going to go through a couple of use cases through COVID today, and what you'll see and what you probably start to understand is that things have been amplified through COVID. For the last 10 months, we've pretty much been at the top of the charts, which is a chart you don't want to be the top of, around transmission. So probably going back to late summer, like July, August, we started going to the top of the country after Leicester, and we've pretty much remained there. Oldham have obviously had major issues recently, but then we took back that top spot. So it's been an incredibly challenging 10 months. I'd probably go so far as to say, we are more challenged than most councils, given the challenges through COVID. It's been breakneck speed and massive impact work. You've seen the results coming out this week. Greater Manchester did a piece of research that said you're more likely to die younger. And through COVID, I think there's a 25% increase in or lessening of life expectancy. We picked that up right early on through our public health director, Dom Harrison, for Blackburn. He could see these inequalities building, and they've been massively amplified. So massively challenging times. So what I'm going to talk about first, I'm going to talk about agile and delivery a lot in this presentation today. And I'm going to try and show you the cases that we've been through, but also show you why I think we've been able to do them, why I think we've been able to do them quickly. And one of the first things to say is that we built foundations before COVID hit, and they've served us well. So I think with digital transformation, I started my career in technology and doing the techie stuff and bringing that to the business, and then moving more as digital became, you know, more of a scene, if you like. It's changed more towards behaviours and the front end of the digital. But you need really strong foundations, and we started building them back in 2019. So I told you about the political buy-in and the change of portfolios that we put in 2019. But we also signed the Local Government Digital Declaration, which was a national charter, if you like, for councils. And it held us to account to deliver in a certain way, to share, to work in the open, to drive open source, and many other things. But one of the things we tapped into by signing up to that, and this was like the government digital service were behind this really, we tapped into training, and we put our teams through the Agile for Teams course. And you can see people playing with Lego at the top of that slide and with Post-its. And this was the first time we'd started going down an Agile and a service design journey. Previously, our projects were very much waterfall, you know, Prince 2 projects. And you've heard FutureCover, who are kind of masters in this world, and talk about minimum viable products, MVPs, and iteration. And this is a journey that we started taking the team on. So we put the core digital team through that training, and then we designed our own course internally and started rolling that out across all the sections that I had a remit for. And then beyond that, as we started building different projects and products across the business, we put other people through different from different business units through this. So public protection, social care, reablement, they went through our agile training that we created off the back of that. So this was in 2019, and going towards into the pandemic, we'd done all this training. So we started to look at, you've heard today already about multidisciplinary teams, multidisciplinary project teams. We'd started to work on that. We took inspiration on the right-hand side at the top. Obviously not expected to see that properly, but that is online, and you should go and have a look at it. It's the Spotify engineering culture. So this is kind of a famed model of agile delivery, and it's based on trust and autonomy. So you can go and Google that, the Spotify engineering culture. And this was kind of starting to inspire us, and things like the government digital service, the GDS service, all that they were doing, and stuff from around Europe and the world. So we started looking at how we should deliver this. So that was all tying in strategically. And then we restructured as well in 2019. So we started to put a focus on service design and agile in the structure. So this is really important as well. You can't just do this stuff. You've got a structure for this stuff as well. And then on the technical side, we started to move towards DevOps through the structure. Now, DevOps is basically taking IT support and IT development and bringing them into one. So you've got less handoffs between the teams as they build things. And that also increases automation. So you get people doing the high value stuff and the lower value stuff. You automate. It's quite simple stuff. But we restructured around DevOps and service design and agile. So it looked very different than when I first started. And we're just actually going through another tweak of the structure that takes us further into that world. So we've got loads of design roles now: assistant designers, apprentice designers, senior service designers, user researchers. We've got DevOps, senior DevOps engineers, junior DevOps engineers. We just didn't have those roles back in 2018. So this is a capability we've built. And then the technical foundations, we built we brought in a low-code digital portal platform so that we could build forms, and anyone could build forms, you know, essentially. We brought in Office 365 and went into the cloud with a lot of our back office apps. And we also kitted out the services with mobile equipment, so laptops, tablets, and this was all in 2019. So what the message is: build the foundation, and it doesn't matter when you build it, but you've got to build strong foundations, otherwise things will unravel later on. Okay, I'll move on to the next slide. So one of the first things that we looked at was the front door. You've got to get the front door right. And this was really interesting, coming from NHS to local authority. So everyone who's in a local authority, I know, will understand this, but the front door to the council is the website, and anyone who's trying to do anything with the council, you know, whether it's bins or council tax, that's the place you go. And I found that very different than the NHS world I'd come from, where the websites were handled in the comms teams, and they're basically just, you know, here we are, here's how to find us, here's some services. With the councils, it was much more transactional, and you could do a lot of stuff. You could almost do everything on the council website, and that's what we're trying to do as we drive to channel shift. And I think the NHS, it's moving that way, and it will move further that way, because obviously NHS has moved more towards a self-service model, and that's been accelerated through COVID. So this was the website before. This was when I joined, this is what it looked like. It didn't work on a mobile very well. There was big gaps on the screen. It just did not look very good. It hadn't changed in 7 years, believe it or not. So I inherited a project a capital project to redesign and rebuild it. And it was interesting. Another wake-up call is that being scrutinized so much, particularly by the media. So everything that we do, every case that goes through that's got any sort of money involved, ends up in the local paper. So suddenly it was, you know, front page or nearly front page news that we were redesigning the website and spending, you know, X amount on that. So that was a real wake up, that, yeah, you've got to get absolutely everything right. You've got to get your reports right. They're going out into the public. My quotes are ending up from these reports in the papers. So if we move on to the next slide, you'll see how we built that. So this is what it looks like now. This is what it looked like yesterday. It's built now with our customers. So we have a team of user researchers working with residents to design it. So we started off through COVID. We went out and built a user panel, and I think we got 1,200 people signed up, which was amazing, and a huge amount of people who wanted to help us design our services, our digital services. But it was also a little bit scattergun and too much. So we've reined it back, and we've started working with groups of people who've got a particular interest or a particular skill. For us, it might be a group with learning difficulties, learning disabilities. It could be teams of volunteers, you know, etc. So we sort of specialize in the residents and the users to work with. So we've built it with our customers. We've been through accessibility testing and re-engineered this and iterated it. We've been through iterations this year on this as well. This was first launched in 2019, but we've iterated it constantly since then. It's now mobile friendly. It's data driven. So data drives the buttons at the top that say COVID, council tax and waste. They're driven by data. So the highest hits go to the top, the highest used pages. It's also open source. So we've heard a lot about open source. I won't talk too much about that, but it's built on Drupal. So the code can be shared, and there's a really good Drupal open source movement across a number of local authorities. I think Brighton and Hove and Croydon have spearheaded that work. And it's great that we can start to make this look more uniform across the country. And what I'm really after here is it looking like the gov.uk experience. And we're not there yet, as you can see. That does not look like when you redo your driving license or your car tax online. I want to move us towards that way, and that will be through iterations. And it's also devolved. So when I first joined, we had this project to redesign the website, and it was like, Paul, do you agree on this design? Can you sign off that design? And our exec member, our political member, do you sign this off? And you know, we'd have various comments about that. What I sign off now is that the process has been followed. So have you worked with the user panel? Is it accessible? Have you been through the charter and the plans that we set out? And if you've done that, then I'm fine. That's what I sign off. I don't sign the design off. So that gives like devolved autonomy, but it also drives the right processes. And then just on the next slide, it just shows you this is part of the plan that we've developed. So it's really clear. This is just a section of it. So it talks about the objectives to optimize blackburn.gov.uk so that it's easy to use and for a primarily mobile first customer base. So you can have a look at these slides as you go, but that's just part of our kind of charter vision. But it means the team can go away and work to that to deliver the product. And if anyone wants me to share the whole document, I can just drop me an email. And it's so critical to get the front door right. It gives people 24/7 access. People are using mobiles now. People need the accessibility. It's absolutely critical to channel shift. If your front door is not right, if your website is not right, you can't really channel shift the rest. You know, a lot of the demand coming through the website is through web chat now. We brought web chat in pre-COVID, but it's really ramped up the amount of people using that different channel. And just one other point, when we've iterated this through COVID, the team have been using Miro or Miro boards, M-I-R-O, which is a collaborative tool to do agile work. So basically Kanbans and loads of sticky notes, but virtually. I'm sure some of you have seen this through different conferences you've been on, and they've been fantastic, because I can then dip in and have a look what teams are doing, how they're iterating. I can see all the different versions of that website as they've been going through the process. So really valuable digital tool. Okay, so the next slide. Now I'm going to talk about the Help Hub now. Now this, I won't talk about it too long because this has been covered pretty well by FutureGov, but we went through something very, very similar. We did this ourselves, so we didn't work with a partner as such to design it. We launched it very, very early in the pandemic, so it was launched on the 26th of March. And what it was, basically, it was set up to feed vulnerable and newly vulnerable people and get them the essentials and get them support from the third sector. So we had to redeploy a lot of staff. They came from leisure centres, which had closed down. This is a point in time. It's a slide I've took from an earlier presentation I did to our board. But they took thousands of calls, and they continue to take thousands of, well, not thousands now because the need is not big, but a lot of calls. We made a lot of outbound calls. So at this point in time, we'd made 7,000 outbound calls to check if people were vulnerable. We also had the shielded list. This has been covered already, but we had shielded lists coming from government. We needed to double check. We needed to deduplicate some of that information. We ran 9 to 5 service, but we were Saturday to Sunday as well. But it was all online. It was digital 24/7, and this was on our low-code platform. So that phone image there, that shows that we put these forms on, and a lot of the demand was coming in out of hours. So, you know, if you're newly vulnerable, that doesn't happen between 9 and 5 or 9 and 12 of the weekend. It could happen anytime. And we were workflowing this stuff through all of the time. And in the big heart section there, that just shows you the kind of partners we work with. So we had a triage team in the middle. So you'd call, if you called us, we filled in the online form for you, or your carer or family member or yourself could fill in the online form, and it'd come into the triage team. And they were existing teams, really. We had community connectors who were linked in with the third sector, Age UK, our community voluntary services, loads of charities, local shops. So it could be a corner shop who were getting a food delivery out. We had our children's services team. So actually, there were people in some real situations, and we had to get our social services to support people, both adults and children's. We had our Care Network, which is a voluntary organisation, and our volunteers. So they were all linked in. But the important thing was this was workflowed. So you'd fill in the form and it'd workflow you to the right part of that team. And with the third sector, it would pop out an email to Age UK, for instance, with the breakdown of what that person needed. So it was all digital and it was all electronic. At times, it was a bit Heath Robinson. You know, it wasn't like perfect workflow to the nth degree, but it was digital. It was 24/7, and it was moving around the system. We commissioned a massive food distribution centre, a 30,000 square foot warehouse, and we had suppliers, Sainsbury's and other supermarkets coming through, and we had our own transport vehicles going out. So school buses were then food and essential transport, and at this point we were doing over 2,000 boxes a week. Interestingly, I mean, there was huge numbers here, 1.2 million food projections, and it came in around that. And we did about 42,000 boxes to the end of June. And then we stopped doing the boxes at the end of June because we'd moved into a different phase of COVID, so we stood that down. Now, the last point in the key facts is really interesting. So only 5.5% of the parcels were going to shielded or known vulnerable. So 95% of this help was going out to people who were newly vulnerable. And I believe, and this would come out later, maybe, but we kept people isolated during those early days, and the numbers in Blackburn were very low up to June, and through the summer the numbers went massive. So I think we played a part in, by standing this up so quickly, and it was stood up in a week or two with from nothing to the whole distribution centre. The digital forms were set up in a couple of days. So that must have had some sort of impact. So if we go on to the next slide. Oh, something's gone wrong with that. Right, the format's been lost on that, sorry. So I'm going to talk you through, it's a nice slide, it's just got a heart on, but I was going to talk you through our contact tracing work. So this is about local contact tracing service. So you'll all know about the national service. If you work in authorities now, you'll know that we've got local services everywhere. We, with Leicester, were the first ones to go with a local contact tracing service, and we designed the blueprint alongside Leicester. So because we were number one in the country, we had to do something different. Contact tracing was only successful to about 65%, and we needed to do something differently. So we stood up our own, working in partnership with Public Health England, and we were then able to get about 85 to 90% of people contacted. And these were contacts of people with COVID. So really important work that you'll all be well versed in. Obviously, we've had so many issues nationally with contact tracing, and the Dido Harding, publicity that everyone will have seen. There was a lot of focus on this. What we did, we built off the work with the Help Hub, and that was kind of the core of the offer. So what was happening? The national team were ringing people up, and often they wouldn't pick up the phone because it wasn't a local number. And you know how people get scammed so much these days, they weren't trusting the numbers. And if they did speak to someone, they weren't really that interested in having too much of a discussion. So when we stood up our service, we found out actually there was a lot of vulnerable people. So there was a lady who didn't actually speak English. She was Eastern European, and we got a translator in to help her. Now, she had a daughter living with her, I think just a mother and a daughter on their own. She was in fear of her life because she was isolated. She didn't know what on earth was going on. So we got a translator. We got the Help Hub then integrated with that family. And this was key part of the offer. And that was like the value add for doing it locally. Again, it was workflowed. We had a lot of data coming in. So we had the lists coming through the Public Health England systems and the national systems. We were checking that, deduplicating that data and correcting that data locally using our different systems that we had. And then it was going into the hubs, the Help Hub, to get assistance. And it was also going to our public protection team to do some door knocking and see if people were okay and make sure that they were actually isolating when they needed to. So it was a massive partnership effort. We shared that blueprint across different authorities, and then we shared it nationally, and that became the blueprint, and it's been iterated many more times since, but we're very proud of that work. Was that digital? Yes, it was in part, but really the lesson with this one, it was agile stand-up. It was a minimum viable product that we stood up very quickly. It was 2 weeks from saying we need a local service to going live. There was a huge amount of detail in the process design there. So we went back and did a lot of business analysis, working with teams. But there's a team of 20 people now taking calls, working with public protection, knocking on doors. That is there to this day, and that was set up back in August last year. So there was a lot of agile governance. There was daily stand-ups, show and tells, basically presenting, what the product looked like at that time. I was leading that, and I was co-lead on the Help Hub. And what helped is that you had a senior person there with the autonomy to get on with it. I didn't have to go through masses of governance. I was just told to make that happen, and obviously to make it happen robustly and safely. One of the things that happened off the back of it, we had a media frenzy. So I ended up on the news. So I know one or two people tweeted me, they saw me on the news, which was a terrifying experience on every channel. But the bad thing that happened was that Public Health England got attacked through that, because everyone was spinning our story to attack the national system and say you should have put your money in local, when we were trying to develop partnerships. So that was a bit sad, but yeah, the media frenzy that Oldham have had and Liverpool have had was quite an experience. And yeah, that's now business as usual, and we've gone off the back of that with a bid that was successful to get money to do test and trace innovation, which was called the Social isolation pilots, one of 10 places in the country. We got that for our wider area across Blackburn, Blackpool and Lancashire County Council. So it really proved good. We'll get the slide sent out so you can see the kind of blueprint properly. If we go to the next slide, please. So this is just to show some of the forms and some of the web design. I won't go into any detail, but just to say that our low-code platform and our website, we went through lots of agile sprints, and it brought us very close to the business. People had 24/7 access, the public had 24/7 access to these forms to do what they needed to do. It also freed up our phone lines, which were being massively hit, particularly last year. Our most challenging one was when we took the waste and recycling centres online for booking. Not many places did that, and we were brave to do that, and it certainly caused us some pain. But we had about 10,000 appointments per month being booked in across 2 sites. And that was all digital, that you had to go online to do that, or ring us for us to fill in that form for you. And then the next slide, I'll just quickly touch on the way we use data. So again, pre-COVID, we were using data, or we'd started to bring in capability around Power BI, which is a tool, an infrastructure, and part of the restructure brought through some data people, specialist data people. And we really started using it in anger in COVID. So the iteration at the top from left to right is where we started with the COVID-19 dashboard and where we've ended up. So we just started tracking the PHE data first, Public Health England data. And on the right, we then started bringing in the local hospital data, ONS deaths. We had the virtual ward, which was people who've been discharged and in the community. One of the main points from this is that we started sharing real data across partners, NHS partners particularly, for the first time in a live sense. And also, these results that were coming through to us were the future demand of the hospital. So there was a 2 to 3 week lag, and to see that so starkly, and our top team are on this every day. Our chief exec looks at that dashboard every single day. We then moved into secondary impact. So the bottom left shows you universal credit, and you see the spike, you see the trend that's gone up through COVID. Isolation grants are tracked through this one isn't used as much as the live COVID dashboard on the top right, but it has been used, and particularly of interest to our membership, our political members. And then the bottom right is actually testing data we took from Public Health England and visualized it into wards. So we can see the ethnicity, we can see the ages, and you'll only be able to see it when you zoom in on the slides later, but you can see I've just dragged the data over to show June's cases. But if you look at the recorded age, you can see where the vaccines helped us. And I can drag the sliders and it shows me how this thing has changed over time, and particularly how the vaccines worked. Okay. Next slide, please. Okay, I'm just running over a little bit, sorry, but I'll go through these slides quite quickly. This is just to say that we work in the open, we share in the open. I get the team blogging all the time on this digital and business change website. There's a link there for you to go and have a look. So there's some good case studies, and that's part of the digital declaration, and all of the other good councils that we learn from. They do blogs too. So Essex, Croydon, Brighton, some brilliant blogs out there, and they really inspire us, and we then share ours. And it's nice when you get some feedback back from others. It shows that we're playing a part in that. Okay, if we just go on to the next slide. Right, some lessons. Really want to be clear that this has been very tough, and there's been some clear lessons that we've learned. So first of all, we had some data security challenges. Our low-code platform, we'd rushed these forms out. There were some issues with those forms. We had to go to the ICO and tell them about issues. Because we'd mitigated things so well, it wasn't taken further, but we had massive data challenges with that. So governance, training, testing and supplier management and specs, really important. So what had happened, we'd brought in a lot of tech before COVID and only planned to use it probably like towards the end of 2020, but we had to use that tech very quickly. We chose to use that tech very quickly, and sometimes, you know, when you do that, mistakes can happen. So we had some downtime as well. 90% of the workforce started working from home overnight. So we had downtime, we had to build new infrastructures. We had some errors and technical change management issues. Now, when you talk about digital, I know people don't talk too much about the tech, they talk more about the behaviors. but without the technical foundation, everything else will kind of fall down. So we had to make some changes. We've got some audit people in to have a look at our process. A point there about it can take leaders, the crisis can take leaders off the balcony where you're supposed to have the overarching view and onto the dance floor where the operational stuff's happening. And that happened with me with the hub and the test and trace, and I had to kind of extract myself away quite a lot, and that took some time to do. And also we had some recruitment issues. So in COVID, it was difficult to recruit, difficult to find people. We were interviewing remotely. We had at least one role that didn't go well, and that had repercussions. So waiting for the right person is a lot easier from the fallout from recruiting the wrong person. Okay, if we move on then. So I won't go into these two slides. I'll leave them for you to have a look at, but this is our strategy going forward now. So we've just published this in the last few months. This is the crux of our digital strategy. It's about high-performing organization with agile right at the center. It's about customer experience and the pyramid that you can have a look at later about getting the right outcomes for customers. And then it's about the place. So for the public, connected place, sort of smart cities, connected places, technologies, better access for people in homes, better skills, and then advanced digital skills so that we can turn this economy the right way. Okay, the next slide. These are a set of principles that are in our strategy. I'll just let you go away with, but these are in order. So our technology will be tested against these 6 points. Is it customer-centered design? Is it secure by design? Is it cost and quality effective? Is it digitally first and inclusive? Data, using data to drive wisdom. And data and insight and wisdom are different things. So worth understanding that, you know, the raw data is just that. And then being open, flexible, and cloud first. So take those away. In the notes of this presentation, you'll see the link to our strategy, or you can Google Digital Strategy 2024 Blackburn. Okay, and then final slide. Just some key take-homes that I think are take-homes from this, and you'll derive your own. But developing agile and service design in the organisation has been absolutely key for us. I think that has been the key factor in us moving fast with some of those key impact schemes for our residents. It was touched upon this before, the second point, be ruthless in prioritising where you find out resources are going to be applied and focus on impact, quality and return on investment. So I think COVID has shown us to look at business cases differently, to look at priorities differently and get on with the things that are a real priority. Third one is about creating a simple strategy, simple digital strategy, clear and owned plans. So again, pre-COVID, all of our different business units, we got them to write a digital roadmap with us. So we had some clear accountability and ownership across the business. And be persistent with the language and the approach is to create a culture across your business. That's absolutely key. The fourth point, digital leadership is everyone's job. So it's not just my job and my team. And I tell that to the top team all the time. It's not just an annual board development session, which is kind of what I was used to. This is about everyone owning it. And often I will mirror back questions to me, to other directors and say, you know, your business is digitally driven. So work with me. It's not just my job to sort that out. And then the last one, I just want to say that what I presented is a summary of the efforts of a big team, a brilliant team at Blackburn with Darwin Council. I'm kind of the figurehead for this today, but I'm really proud of what the team do. And they've been nominated for an award at the IESE Award later this year. So we're one of 3 finalists, and hopefully we'll get a top prize out of that. But I'm really proud of what we're doing here, and thank you for the time. Sorry, I've gone a little bit over and it will eat into the questions, but back to you, Jen. Thanks.
Not to worry. It's all really, it's worth every bit that you have to say. So there are a couple of really good questions in the chat. I think I'll just bump in with one real quickly though, is if you had to sort of give us one piece of advice for communicating in that rapid turnaround, do you have any, is there any one little nugget that you would share? Yeah.
Well, I think being being amongst the teams was helping, certainly for the Help Hub and certainly for the contact tracing. I was very much part of the MDT as the SRO, as the senior person. Communication, though, you know, I've reflected a lot through the pandemic. You know, how do I communicate better? I did a lot of videos at the start through Teams, pushing out to my whole directorate. I didn't get a lot of feedback, and it kind of knocked my confidence with that method. I was doing a lot of emails at the start. Again, not a lot of feedback, but I guess, I mean, I've read before and heard before. When you're communicating too much and someone tells you, that's when you're communicating well. So yeah, get amongst it and try everything.
Get off the balcony and onto the dance floor, I guess. Yeah.
And yeah,
I like that. I'm going to use that analogy again and again. And I think what you're saying is also that, you know, you can put out information, but there needs to be a feedback loop, you know, that can help that information get shared more quickly. So thanks, Helen and Pam. I'll also turn it over to you guys.
Yeah. Thanks, Paul. Really excellent. Loads of comments and good response. So I'm just going to pick up on Linda's question where she highlights the great work you've done for the last couple of years, but was wondering how you're going to link that into the ICS development and how you link into your local East Lancs. It'll be, won't it, your FT, whether the learning's being shared into the wider NHS.
Yeah, I mean, through the pandemic, that was, I didn't have time to go through all of the challenges, but we were doing some really good work with the ICP and the ICS before COVID. And when COVID hit, I felt like everyone kind of retrenched and had to go into crisis mode. And the partnerships across like health and social care around discharge got better. But I felt from a digital perspective, sometimes they'd got worse, and we're having to rebuild that. Not worse in a bad way, but just that they weren't as existent as what they were. But yeah, we're doing some work around the test and trace innovation now, and that is building on a place-based perspective. So that's going to be it's a pivot that's going to lead the way for that. But yeah, having regular conversations with our hospital and with GPs, and yeah, it's been tough. It's been tough, and it's going to take some work to re-engage it all properly.
Great, thanks, Paul. So another one from Dilys Quinlan. Excellent presentation. Looking to the future, what plans do you have in place to increase and improve the numbers in communities, especially children and young people, to have access to digital technology? So yeah, so this is all rooted in partnership, and this I didn't touch upon. There's loads of work that we did, you know, from funeral streaming to helping schools and helping children, pushing out laptops from the government out locally. But it's part of our strategy now. So I think what I found difficult since coming in is that, and other places have done this better than us. Stockport did a great job of this with I think it was called the Did You Know project around digital inclusion. We'd started some work pre-COVID. We'd built hubs in our libraries, working with the Good Things Foundation, a charitable partner. But then when COVID hit, obviously we went into crisis mode. So going forward, it's about working with partners, getting the offer really clear to people. And I think just being able to mobilize that better and bring many constituent parts to make a whole lot on that, both for adults and for children. But with children, obviously we've got very strong, we're a unitary authority, so we have education. So we work with schools, and the schools have done a brilliant job around this, and it's working with the private sector too. So we've had a bit of private sector work through COVID to get disadvantaged children access to the internet. So not an easy answer to that one. There's other councils that have done brilliant work, but we've got big ambitions there too. Right, and just a final one. So I loved your digital is everyone's business. So leading comms in a small organisation sometimes, and your reference to the website as well. And that investment that you had in agile training, and I guess there's an ask whether you'll share some of that information, whether you're able to provide us with some extra detail of what the training looked like.
Yeah, I'm sure we can do that. I mean, the blog's a good place to look because it probably gives you a high level insight into what we've done, but we can share detail. I mean, if anyone gets in touch, we can do that. I think that was something I noticed. I'd been following GDS for years. I've tried to get a job there back in 2015 or 2013. So I followed all that like agile service design stuff. So when I got here, I was really keen to do it. And I noticed that in the NHS world I'd been in was not up to speed as much, apart from NHS Digital. Now NHSX are coming that space, and then there's forward-thinking trusts and CCGs that are down that line. So I think that is completely the future, but it needs to be the whole business behind it. And that's something we're still challenging ourselves with, because yeah, we've got probably a couple of hundred people trained, but I need to get like 500, 700 people trained. So it's all about the culture and getting the buy-in from everyone.
Great. And then just the technical one from Paul. So I'm going to read it because I know not what it means. So well done on your presentation, but he's interested in which low-code platform you're using, how devolved you have gone, and whether you are looking at RPA.
Robotic process automation.
All right. Okay. Thank you.
I hate acronyms, but I always use them, and so I have to try and, especially when I present, say what they are. So we're using Abavus. That's the platform. There's some good platforms out there. Netcall is a very good platform. I've seen some really forward-thinking councils use. We have Netcall on our customer service side, but ours is called Abavus, and it's got an app and it's got this platform. We've got a design team in the digital team that build those forms. So we've not started pushing that out, so everyone can create one yet. It's got to be controlled, and we've got a specific scope for the project for the first 2 years. But the design team has grown. So it started with like a couple of people. Now there's probably like 8, 9 people. So I would say with that, yeah, bring the platforms in, but bring your people architecture through first or at the same time, because that's so important.
Okay, lovely. And Paul says he'll be in touch if that's okay.
And the RPA, we have been doing some work, the robotic process automation. This is about how you shift data from one system to the other, how you get your systems talking to each other and making it automated. So we have done some of that with the people side of the business, with social care and children's. So it's very much a live one. I wouldn't say we are mature in that area though.
Okay, lovely. Thanks, Paul. I think that's about it, Jen, unless you can see anything, Pam.
Oh, I think we're good. Great. I see Pam shaking her head. So I think that's another good area for follow-up, right? That sort of platforms meets people, and what now? I think there's a lot of interest for, we've got our ears to the ground all over the system, but and this will touch, Simon and Chris are going to probably touch on some of this in the next bit around access, but also that capacity and capability within your organization to move things along and keep things evolving. So I think probably, Paul, you're going to have a lot of people reaching out who are like, how did you do that? What did that look like? Yeah. So that's really good. And I think this is great. We're gathering information as a group. We're putting our heads together, and then if we can take these discussions further and say, okay, you're good at this. What can I learn from you? We can share this with you. So love it. Thank you so much, Paul, for all of your input this morning. So I'm going to bring in our third presentation, but I also wanted to mention, and I'd forgotten to mention this earlier, is that there is an evaluation also for this event. So Effie, can I invite you to put that into the chat just in case folks have to jump off for another meeting or something like that, but I just thought I forgot to mention earlier. And so we'll put it in the chat later as well. So, or if someone can put it in the chat. Thank you very much. Just sometimes I forget. So as long as it was in my brain, I thought I might as well just share it. So thanks again. And now, again, a good segue into telehealth. We're going to hear from Simon Minford, who's Clinical Innovation Consultant and Clinical Lead for Digital at Alder Hey Children's Hospital. And then we've got Dr. Chris Dewhurst, who's Clinical Director of Liverpool Neonatal Health Partnership. So really excited to hear a little bit more about their experiences implementing telehealth and what those lessons learned were. So Simon and Chris, if you are ready to share with us, we are eager to hear what you have to share.
Right, so good morning, everybody. My name's Simon, as you heard. I'm going to see if I can seize control. fingers crossed, it works.
That's kind of an old school way of leading, is seizing control, but I'm kidding. We're sharing, we're being transparent.
Oh, we have it.
Yes.
There we go. So I think we're going. This will be a presentation of two halves. Chris is going to kick off, and I'll follow up with the second half. Chris, do you want me to do the slides, and you take it from here?
I
Okay.
know Chris is here, and I'm wondering if Chris is just having a difficult
Okay,
time.
well, I'll kick off then. I'll do his bit. I'll double it. You snooze, you lose. So so this is a brief overview of the Liverpool neonatal picture. The care for our families is split over two sites, and whilst they're close, it's still far. So there's a two-site model. The infants that are just critically unwell stay in the Liverpool Women's NICU, and the children that and neonates that require surgery are looked after in Alderhay Children's Hospital. And we have two experts with a gap between them, and there's transfers in between. Liverpool Women's Hospital is a high-tier delivery hospital, so it will deal with all of the difficult deliveries in the region. So people will come from a long way to have this. It can be women at risk, or twins, or if they've scanned and had an anomaly, so that all the experts are there for when they're delivered to get the care that they require. The flip side of that is Alderhay does the surgery part. So how do we join them together? And both sites do really high level care, and Alderhay will even do PICU, ECMO, all of the tertiary, quaternary level stuff as well. As part of our journey, we're working towards the NICU of the future, and this is a new build neonatal unit on the Alderhay Park site that is due to be built in the next 2 to 3 years. As part of that journey, the neonatal teams and the pediatric surgical teams were exploring telehealth, and we almost a year and a half ago now, it seems like forever because the world has just done so much, but we invited Jennifer Fine over to talk, and she's a doctor from the Mayo Clinic, and she has set up a tele-neonatology network. And what this does is across the state, their geography is really spread, and how could I put it? It's very difficult for those satellite areas to be competent in looking after a troublesome neonate when they're born. So if they decide to get sick, so if they decide to get sick, they might have the expertise they need on hand. So what they deliver is a resuscitation support service. So when a baby is delivered and the baby's incredibly unwell, they dial in during in a telehealth capacity and guide them through the resuscitation. So this is really cutting edge, but also it takes a really niche expert and puts them right at the patient's bedside, even though geography dictates otherwise. And they found that it drastically improved the healthcare outcomes. The babies weren't getting as sick, and they were getting those key clinical decisions at the bedside. And in American parlance, it dropped their litigation bill to zero pretty much as soon as this was implemented, which is really big for them. For us, it just means it's massive quality of care and incident avoidance. So we thought this was amazing, and we brought Jennifer over and had her picture view and looked at how we could potentially adopt that into our network. However, at the same time, next slide.
Hello, everyone. Sorry.
Please jump in, Chris. Please jump in.
Can I apologise hugely? Just before I was about to start this, I got an urgent phone call from the hospital that I had to take, and then I turned around and heard Simon's beautiful Irish dulcet tones. So hello everyone, my name's Chris. I'm one of the neonatologists from Liverpool Women's Hospital, and I apologise for missing the start of my own presentation, but I have got a reputation anyway. So thanks, Simon. Am I okay just to take over now?
Do it, man.
Yeah, so I think Simon's
understood your service more likely.
Yeah, Simon's probably shown you the that we met with Jennifer Fang from the Mayo Institute, and we really didn't know what telemedicine was going to do for us. We were looking at how we could use it across the two hospitals, but we didn't know in what capacity. We didn't know the use for it. It was basically a bit of a let's have a look at this and see what it can do, and had no idea of how we would use telemedicine. So that was on the Monday, and I'm going to fast forward to the Friday. And those are the headlines there in the newspaper. You can guess which newspaper if you wish, on the 7th of March. So if you take it back to this point in time, we didn't really know what was going to happen. We'd seen what was happening in Italy, and we'd seen what had happened in China, but we were still a little bit complacent in the UK. We'd just had the second death, but stuff was just starting to ramp up. In particular, I remember having a meeting on the Friday morning about how the university was going to cope if a number of the execs were off sick. And so that morning, if you press next slide, you should get the phrase up. I said to one of my colleagues, this is Fawzia Pays here. I'm not sure what we're going to use that telemedicine system for, but I think we're going to need it. Can you get it? And so next slide, please. So one of the reasons I thought we might need this is to do with some sickness we had in the consultant team. So we normally don't have sickness at all in our consultant team, but we had 3 people off on longish term sick prior to lockdown. And when lockdown was announced on the 23rd of March, and again, we've probably forgotten this, but basically there was all sorts of, if you had any temperature or cough or you were sniffly, you had to shield for 2 weeks, and there was no testing at this point. So we lost another 4 of our consultants. So suddenly we have 7 consultants to provide 14 consultants worth of work across 2 hospital sites. So we'd lost about 40% of the clinical time to our service. And this meant the service was unsustainable. It meant that there were threats to the babies in Liverpool, particularly relating to surgical care. And some of our, for want of a better term, rival hospitals in the region were already starting to look at how they could take the activity into their organisation. So on Monday, the 23rd of March, 2020 is when we went into lockdown. Our service was becoming unsustainable. So next slide, please. So there's Simon, and Simon, over the next 2 weeks, managed to get the equipment. So there's one of the robots there you can see, into both Alderhay hospitals and Liverpool Women's Hospitals. We managed to get information governance approval from both sites. We got IT involvement on both sites. We got everything signed, approved, done and dusted within the 2 weeks from asking for the equipment to the equipment arriving. Now, normally this sort of high-end tech equipment arrives very well packaged in lorries, which are delivered straight to the hospital. This is how, that screen at the bottom is how this high-tech end robot arrived. And quite literally, Simon had to pick this up from a car park in Runcorn, I think. And that was the text message or the WhatsApp message I got saying, I have the package. We then had to decide, how are we going to use this? Where are we going to use it? When are we going to use it? And actually, why are we doing this? So if we go to the next slide, please. So that was the 24th of March. Fast forward 2 weeks. Within those 2 weeks, we trained the consultants who were shielding at home on how to use the robots. And we trained them in where and when we were going to use it. And we basically restructured the work pattern so that we had a virtual consultant. And on the top picture there, you can see one of my colleagues, Bill Yoxall. So he was someone who was told to shield and couldn't provide any direct face-to-face care. but there he is conducting the first ward round, which took place 2 weeks after the equipment arrived on Monday, the 6th of April. So the shielding neonatologists were providing ward rounds into Alderhay Children's Hospital, and there they are in the top picture on the neonatal surgical unit. They were also providing a full ward round into our special care or low dependency area in the Liverpool Women's Hospital. The surgeons were providing cover into our neonatal unit at Liverpool Women's Hospital. And on the bottom picture, you can see one of our surgeons, Jo Minford. She is seeing a baby who's in the incubator. Next to her is the father of that baby. And on his phone, because at that time we were only allowing one parent to visit, is his partner. So you've got a full virtual assessment of this baby that didn't need to move between the organisations, and people could see the babies from wherever they were. Next slide, please. So this slide just shows you how quickly we implemented a whole new programme to keep our service afloat. So the 2nd of March was our first introduction to telehealth. We'd never considered or thought or heard of it before that. The 7th of March is when we said we need the equipment. The 23rd of March is when we realised what we might be using this for in terms of people we're going to be shielding. 24th of March, the systems arrived and the first ward round took place on the 6th of April. So that's just over 4 weeks, or maybe 5 weeks from first hearing about it to having a service up and running. So next slide, please, for Simon. I'll hand over to Simon now. So if we take that sort of 5-week timeline and push it out over what we did over the rest of the summer, we can see that, well, you've probably seen in the picture with Dr. Yoxall that we literally had begged, borrowed and otherwise acquired the equipment. And whilst we had complete proof of principle, we very quickly realized we needed more equipment and of a higher specification. So quickly after the surgical and neonatal teams were fully trained up, we identified the need for and procured some more devices. And they arrived on the 1st of June. And we deployed 3 of those within Alderhay and 1 in the Women's Hospital. And from that point, we built on the service. And as of August, there were 130 consultations in that 1 month alone. I think there's a little bit of lag. I don't want to rush the slide, but in getting that new equipment, you can see it here. This was built in the States. I think this is Santa Barbara, but they assembled the equipment for us, which was in pretty high demand at that point in the pandemic, and we got that shipped over and delivered. Whilst we were doing this deployment at pace, improving the technology, teaching the staff, we also needed to listen to the families, listen to the patients, and listen to the staff to make sure it was hitting what they needed to hit. So we very quickly deployed a QR code based digital evaluation for the families, and that was done regularly, just to make sure it was okay. There's a lot of nervousness over not seeing the doctor. There's a bit of a bond that we don't quite appreciate until we're there, that face-to-face consultation is really important, especially when you're talking about something as precious as your newborn child. However, the evaluation very quickly let us know that this was very warmly received. They could see, hear, ask questions. Traditionally, these discussions between sites would happen on a phone in an office without the parents being part of that consultation. So this involved a bit of a change in the dynamic and a change in the relationship. And the parent was present during these discussions. But what the parents were telling us was they could see, hear and ask questions. They knew the plan for their baby. And
even more than that, 40% of them said it was just as good as a face-to-face consultation, which stunned everybody. We had this natural thought that it's just not as good, but can we make it good enough? But the parents obviously thought it was good enough. And not one parent was dissatisfied with the service they received, despite the speed of deployment and the newness for the entire team as to what was happening. The staff, our staff were a broad mix, but there was apprehension about this new technology, and actually across the staffing group, a significant portion of the staff rated their own ability to use IT devices, computers, as average or poor. I know that during the pandemic, one of the surgical consultants got a smartphone for the first time. So that's the level of IT sort of general knowledge that they had. But despite this starting point, the staff envisaged this could be a way of working in the future. And whilst we couldn't measure it, they felt that it avoided transfers every week of moving sick babies across Liverpool. And for our part, what that did was alleviate the burden on NWAS and the transfer infrastructure so that they could focus on moving adults around. And despite this being all new and everything, most of the staff felt that it would continue in some form when the pandemic is finished. So it was surprisingly well received. And I think the quote at the top really caps it off. They could speak to the parents at length. And in a time of masks and PPE, they were literally seeing face to face. And then the feedback that came from the staff was that they wanted more of it. They wanted access to more specialties that otherwise would have necessitated the babies being transferred. They really appreciated the sort of the camera optical zoom. And I think that's an important distinction. There's two technical types of zoom. One is digital zoom. So the picture just gets bigger and more pixelated. But our devices had an optical zoom, so the bigger the pictures got, the quality of the picture remained, and it allowed the level of detail needed for clinicians to make decisions remotely. You know, the disadvantage was, well, hands-on is always better, but sometimes hands-on isn't always possible. And there are still distinct advantages of being there in person, establishing a rapport, picking up on non-verbals. It is very much a different consultation style using this technology. It's not better or worse, it's different, and there are advantages of both. And yes, our guys wanted to steer the robot, but sadly our type isn't autonomous. This is a small video of it in action in the hospital.
How many, Simon, of these did you guys have?
Of the robots?
Yeah.
So we had three set within Alder Hey. So we had one in the neonatal surgical unit, one in our high dependency unit, and one as the spare.
Okay.
And then we had one in the neonatal high dependency unit in the women's, as well as one that we moved down to the low dependency.
Okay.
And what was interesting about the rollout of these was that once people got to grips with the technology and how it was used, they started using it in different ways. And it was completely different than our use case at the start. The initial use case was partnering up the sickest babies with surgeons and neonatologists to give them the care they needed at the time they needed it. But how it evolved was that a remote neonatologist was delivering like a basic ward, well, not a basic ward round, it's actually really complicated. It's just not intensive care complicated. Okay. But they were doing the low acuity stuff that we weren't expecting to alleviate the burden on our colleagues in other ways. Are we good to go?
Hello, my name is Chan. I'm one of the surgical registrars. So I've been asked by the nurses to have a look at your baby, and I've brought along a robot consultant. So if you don't mind, I'll bring the robot in, and it's Mr. Hennessy. He's the surgical consultant. So I'm quite a new registrar, so I'd like him to have a look at your baby as well. Is that all right? Yeah. So this is Mr. Hennessy.
Hi there. Hiya, hello. Right.
So the nurses have been telling me that the baby's tummy is getting bigger, and they're worried about the baby being sick as well. So I wanted to have a look at your baby's tummy. If that's all right.
Yeah, if you wheel us in closer, and we'll set up the boom arm, and we'll have a good look at that tummy for you, and then we can answer any questions that you have. I'm just gonna look at the observations here. Okay, so that's observations, which are looking good. And I'm going to look down at the tummy.
And he's handling quite well, Mr. Hennessy.
Yeah, it looks very good actually. So looking at him just generally from the end of the bed, it looks good. And the examination's looking very settled as well. Good. And the dressing looks intact, nothing else going on there.
Yeah, dressing's nice and clean. There's no discharge there.
Yeah, and a happy looking
Doesn't
baby.
have any hernias.
Yeah. Well, I'm happy there. I'm happy. So just to reassure you there, I think that tummy's looking nice and non-distended, and I think we'll just carry on with the plan just as we are.
Yeah, thank you.
Do you have any questions or anything to ask?
No, we're happy with the offer. Thank you.
Thank you very much.
Do you want me to move the slides?
Yes, please. I think we've got a few sound gremlins, but never mind. So what I think it's going to play its way out. What we're going to see here is the sort of the high definition view that the consultant, who was actually at home when he was called to review this baby, we could see the definition that they could see, and the fact that he could review the baby post-operatively, and that support his junior trainee whilst he was not in the building. And what we can see there is actually the speed of support that the trainee's getting. So it's literally within minutes, and he didn't have to drive in. So the speed was excellent. So the next steps. So obviously, a coronavirus will be evaporating shortly, as our Prime Minister will just put us back to normal. But it's not completely gone away. I know that this week we've had to deploy the robots again, as one of the neonatologists has been asked to shield. And once again, we've had to spin up the service within a couple of hours. But once again, and I think I've actually got a picture that I can share in the chat. Once again, we got a neonatologist back into the hospital and delivering care, and not having and adding that service resilience that we need with specialist staff. So what are we doing next? So as the pandemic response use case ends its sort of natural life, we're going to pick up where we left off with Jen Fang in March, and see where we can go in the future with it, dealing with the geographical separation across the northwest of babies from the specialist centres that may be required to look after them. we're going to explore the use of telehealth in RSV surge planning. So one of the new and emerging challenges in healthcare is going to be this winter in pediatrics. Whilst pediatrics got off lightly as regards severity of COVID infection, these 2 winters of isolation has meant that everybody under 2 has never really encountered many germs before. And the primary cause of infection in children and hospitalization due to respiratory illness is RSV, respiratory syncytial virus. And if anything's going to happen like has happened in Australia, who are a season ahead of us, they in some areas, I think in Brisbane, had a 400% increase in incidences of this, which really pressured their ICUs, HDUs, and emergency departments in coping with this surge. So we're now rapidly using the lessons learned last year and apply them to our surge planning and see how we can use this technology to deal with that. We're also exploring different use cases in specialty areas. And I actually got to use it myself yesterday when we were reviewing a child in Arrow Park with a skin condition. So it was nice that I got to go and Chris wasn't hugging me all the time. And I think that's it. Chris, do you have anything else to add?
No, I don't think so. I think just to say the video of the robot was a bit glitchy. I think the sound and the video screens weren't in sync, but what you could see there was both there's 2 cameras on the robot. So there's one that the boom arm he referred to, you position over the baby, you can zoom in on the baby, position over an incubator, and the other screen you can use to look at the family, discuss with the family. Then you have full control over those cameras, so you can move them around. You could swivel 360 degrees, you can zoom in and so on. So you can actually, and what the surgeon was looking at the monitor as well as looking at the baby at the same time. So it gives you that opportunity to do that, and also gives you the opportunity to plug in any electronic equipment. So you can have an ultrasound scan machine connected in, or a video laryngoscope. So as someone goes to intubate a baby, you can look at what they're looking at down their laryngoscope and advise them up a bit, down a bit, that's where you need to go, that sort of thing. So yeah, I hope you enjoyed our presentation. I just apologize again for having a phone call just as we were about to start. But I think what we've shown you is that, time is not a barrier to setting up these sorts of initiatives. And actually, the pandemic brought some positives. And one of the positives was we kind of cut through the red tape. Normally, a program like this, I bet, would take 18 months to 2, if not 3 years from conception to up and running. And you can see with the right people and the right focus, you can do this much more quickly. So time isn't a barrier to setting up these programs. Thanks.
Thank you, Chris, and thank you, Simon. That was just really, really fascinating. Could see reactions from folks as they were watching. It was really interesting. And I think, what you're saying about it's not necessarily time. And that urgency that's created, that has been created, really allowed for barriers to come down in some ways, and then it also exposed other barriers, that experience. So, what we find a lot as well is that some of the critical time, and I think that we heard this into the first 2 presentations as well, is the time for people to be able to connect and talk through things on the front end of deploying some of these big innovations. And that headspace at the beginning, I'm sure you and Simon spent a lot of time together, noodling through this as you were putting it into practice. So.
Yeah. Well, to be honest, we didn't spend that much time, did we, Simon? Because we just had to get on with it. We had no other alternatives. So a lot of, and we couldn't go and visit each other. We had to do it via remotely. So and all of the training of all of the people had to be done remotely because they couldn't come out of their shielding. So
yeah, we learned so much in such a short period of time. Helen, and do we have any questions you wanted to get to? I think I've seen some
lots of comments. I think you've just stunned people with the speed at which you've been able to adapt this. And for me, what came across was the compassion with the parents as well in what must be a really worrying time for them. Steve Mosby asked about information governance. It's always one of those sticking points. How did you get over that hurdle, and any advice for us on it?
Yeah, so the advice was, interestingly, the telemedicine robots had been put into another trust in the Northwest a few years previously, and they hadn't particularly been used in that organization. I think it turned into a bit of a white elephant, but they'd done all the information governance sort of processes and so on. So we didn't reinvent the wheel. We just took their documents, adjusted them for us with their agreement and with the company's agreement, and put them through our usual processes. The other important thing was to get the people on side, people who've got a can-do attitude rather than a barrier attitude, and having those can-do attitude people around was hugely important. So when we went to people and explained to them the situation we're in and how we could resolve it, we were very much given the green light. But that was I remember at the time, that was the sort of culture of the NHS at that time. I don't know if you remember, was let's just get on with it, let's just do it. And it was fantastic. I mean, I say it's the best in some respects. The most I've achieved in my career was in the 3 to 6 weeks of the start of the pandemic, because all of the things we've tried to do over many years that have hit barriers all the time, those barriers just dropped. And I do remember Matt Hancock saying, we will look at this and we will remove those barriers moving forward, and slowly but surely they've all come back.
Yeah, and there's a few comments in the chat box around that hope that they don't come back, and that we keep that innovation mindset that as you say, we were able to in that 3 to 6 weeks. Are there any other questions for Chris or Simon? If you pop them in the chat box. We've posted a few links to case studies as well, where the Innovation Agency have written up both your work and Paul, so they're there for people.
I think the other aspect of the IG piece was having a really good executive buy-in, and the CIO at Alderhay knew very well the one at the Liverpool Women's, and they both just said, okay, we're going to do this. And once we got the documents in place, having that level of support, it literally just happened. The rest was a technical exercise of getting technicians to make sure they were doing the right thing, that the servers were in the correct place. But because of that work, we could just very rapidly answer those questions, and I think it was done in a day.
Yeah, and do you think the fact that you're both very senior clinicians as well helped with the speed of things?
So I think the clinicians being the ones initiating this meant that you didn't have to get buy-in from the clinicians. The buy-in was there from the clinicians from the start. It was actually the buy-in from elsewhere we needed to get. And I think that really, really helped, because you will know that a lot of the IT and digital innovation is done to people rather than with people. This was very much driven from the front end. So it, I think that had a massive impact on getting it through quickly.
Yeah, and I suppose what I didn't put forward that normally Chris does at the start is there's already a partnership going between Liverpool Women's and Alderhay, and that leadership team just could see straight away that this was not sustainable. So we had instant senior clinical buy-in, leadership and direction. And ultimately, despite whatever advanced technology we do, at the end of it, it's an agreement between one clinician and another clinician and the family to deliver a service. And that can be the big sticking point. And we had that boxed off day one. It was quite clear what Chris was going to deliver from his side. It was quite clear what the surgical team were going to deliver from Alder Hay side, and the rest that drove and give it the impetus to just get it through. Everything else wilted whenever they just went, well, we need to do this. That's it. And that's the core, I think, and it's my big takeaway that I'm going to apply to the next pieces. Is there's an entire project management and how to deliver a service aspect to this, but there's a massive piece about how you develop that clinical accord that allows clinicians just to say, I'm going to do this, you're going to do that, this is what our agreement is, and you hand it off and say, we want to do this thing, you make the technology happen. And for me, that's the key takeaway that I learned, and the most important thing, that clinical agreement.
I have a follow-up question on the heels of that, and maybe it's just a wondering, but I know that the CRN and the ARC right now have a sort of a campaign going around clinical research and clinical involvement and innovation, and a lot of it has to do with sort of, again, just sort of diffusing these opportunities and saying, what are you curious about? What would you like to test out? Do you have any thoughts about what you might say to other clinicians who are on the cusp of potentially taking a step into that innovation space and really just going for it?
So we're still working with the Mayo Clinic. What we'd really like to do now is to introduce it a little bit like the Mayo use it. So currently in our neonatal Northwest operational delivery network, we have some level 3 units, and then we have delivering the highest level of neonatal intensive care. And all preterm babies should be delivered in those areas, but in those units. But sometimes unexpectedly, sick and or preterm babies are delivered in other units, and we'd like to be able to support them using the telemedicine, and we'd like to do that under a research setting with the Mayo Clinic, looking at can we improve the outcomes for babies born outside of the level 3 units. That needs a huge multi-million-pound injection of money to do, and it needs obviously a wider buy-in than just Liverpool. We're looking at Manchester, Northwest, Preston, Blackburn, Blackpool, as far up as Barrow, and as probably over to the Isle of Man and also into North Wales. But if we could do that, that would be fantastic. So that's where we'd like to take it in terms of both clinical, but also research to look at the outcomes on that. So we have had discussions about that, but finding someone who will give us the money to do that is a little bit tricky. So I'm not sure if that was the exact question you're wanting to answer, but that's where we've looked at where it goes. And we are also looking nationally. We're talking to the neonatal networks nationally about how they can use this service as well.
Okay, no, that's really great and really helpful. And I did mention in the chat that my home state is Minnesota. Oh, so right. It was exciting to hear that. And so yeah, go Rochester, Minnesota. Yeah. If you're ever over there, just shoot me a note and I'll send you to a really good diner. Oh, I'd love to, yeah. Well, we're supposed to be presenting in Las Vegas in a couple of weeks on telemedicine, but I'll be doing it from this table here because I'm not, well, yeah. There you go. Yeah. It's the double-edged sword of remote, yeah, totally. No more travel. Yeah. Well, thank you so much to both of you, Chris and Simon. That was really fascinating. And I think that, again, this is a great forum, this collaborative itself, and obviously cascading more widely, but a great forum to say, hey, here's some stuff we want to do. Who wants to get on board? And sort of sharing some of those opportunities. So I think there's, again, more to come. So if Helen and Pam, I think, I'm not sure if there are more questions, but I think we're probably good to start wrapping up. And I think, and Sharon, feel free to, kind of jump in as well, as I'm just trying to summarize a little bit, but what a great couple, great morning and great sessions. Really interesting from my perspective to look through these different lenses of application. Really, really grateful and honored to be able to be here. If you've got more comments or questions, please do put them in the chat. We've got a link to the Survey Hero, which is the feedback mechanism. If you are all about improvement and data, then you will understand why it's so important for us to collect this information from you. So please don't hesitate, or don't skip the survey, please. We really, it will help us drive the future planning of these events. Speaking of future planning, there is another event that's coming up on Thursday, the 16th of September, and this one is on political leadership. So this is going to be really interesting, connecting some more dots. And so please do have a look for those events, and there will be an invitation to register for that one as well. Again, I want to thank everybody who came today and shared. Sharon, is there anything else you want to say that I'm missing?
No, not from me. Thanks, Jen. Just to reiterate on behalf of all the collaborative, a big, huge thank you to all the speakers and for everybody for their input. I think it's been really informative, hasn't it? And yeah, really enjoyed it myself. So no, just huge thank you.
Great. Great. And then I would say, please do go back on Twitter, check out and share links there. That's probably our most transparent open source platform for sharing links and things as far as keeping this work visible. So again, thanks so much.